Hello, everybody. My name is Judit Jockers, and I'm a pediatric resident at Semmelweis University. My topic is the identification of predictive and prognostic biomarkers in polyposis syndrome. My vision is to enhance chances of survival and quality of life in patients with polyposis syndrome, and my mission is to develop an accurate diagnostic and management protocol by monitoring through the genotype-phenotype association. Currently, I have two ongoing topics. And the first one is to investigate the association between the genotype and phenotype of pediatric patients with polyposis syndrome, where we would like to use the methodology of a systematic review and a meta-analysis. So shortly about the background. Polyposis syndrome is a group of hereditary and rare diseases which are characterized by multiple gastrointestinal polyps and an increased risk for cancer and other conditions. They are caused by genetic mutations which alter the function of the affected genes. Thanks to modern diagnostic methods like new generation sequencing, it is possible to detect these genes. Still, despite having these tools, there has no genotype-phenotype correlation been demonstrated yet. In addition, cancer and other conditions are extremely rare, and on these grounds, it is extremely hard to discern the course of the disease and to find the best good management option for these patients. Therefore, the aim of my study is to investigate the possible outcomes in association with the genetic background in pediatric patients with polyposis syndrome, to discern the course of the disease or make an early diagnosis possible, and to find the best management and therapy option to improve the quality of life and enhance chances of survival in these pediatric patients. So my clinical question is, what is the association between the genotype and phenotype in children with polyposis syndrome? Where my population is the children with polyposis, the exposure are genotype variances of polyposis, and the outcomes are the phenotypes with the different type of diseases, which you can see above, with the clinical features, including the onset, course, and the different manifestations. My hypothesis is that genetic variances of polyposis syndromes can be associated with clinical variabilities. So about my first progress. So after we finished the data extraction and we had our first results during the summer, we saw that to achieve our goals, we need a much deeper knowledge about the genetic background. So we included a geneticist, and we had to start research basically again. So about the workflow, the articles we found are mostly case reports, and we had around 200 articles overall for all these diseases, which described the phenotype pretty detailed, but the genotype was only written down with the codon and the sequence. Of course, the chromosome and the gene we knew from the disease background, and we had to do research about the protein change, the type of mutations, the exact location of the mutation, a variant interpretation, and currently we are doing research about the domains in the different diseases. So shortly about the variant interpretation, it's from the American College for Medical Genomics and Genetics, and it shows if a mutation is benign or pathogen, and it has 5 categories. And about the domains are a specific functional region in genes. And you can see here the domains of the APC gene, which is responsible for familial adenomatosis polyposis syndrome. And for example, there is a domain called the armadillo repeat, which you can see the first one, and it's responsible for cell migration and cell adhesion. So in our work, we were looking if the mutation we had, if they're in correlation with these domains, and with the variant interpretation, and we're still working with the statisticians to get our first results in this deep research. And to show you a little visualization about our ongoing work, so here you can see the familial adenomatosis polyposis syndrome patients who had a mutation in the APC gene, and we did the variant interpretation looking at the phenotype. we had around overall 158 patients for this research out of 42 articles. As you can see, we had only mutations in the uncertain, in the likely pathogenic, and in the pathogenic variant interpretation. And we looked at gastrointestinal polyps, GI tumors, and any other extraintestinal tumors. What you can see that we had only one patient in group 3, and around 40 patients in group 4, likely pathogenic mutations, and almost 120 patients in pathogenic mutation group. And out of these patients, almost 100% of the patients showed polyps in the gastrointestinal tract, no matter in which group they were from the variant interpretation. And interestingly, the likely pathogenic showed a lower proportion in showed a higher proportion in gastrointestinal tumors and any other tumors than the pathogenic mutations. And the next step we looked, the slide moved a little bit. So in the next step we looked at the domains, the variant interpretation with the pathogenic mutation and the phenotype to visualize in the different domains. And what we can see here that we had around 60 patients with mutation which was not in a domain, and the rest of the patients, which were left around 70 patients, had a mutation in a domain. And from the proportion we can see that almost every patient had polyps in the gastrointestinal tract, which is very typical for FAP. So that was we were awaiting that. But the interesting was the gastrointestinal tumors, which is very rare in pediatric patients with polyposis syndromes. But there were quite a few, but mostly in mutations within a domain. And also the extraintestinal tumors mostly occurred in mutations which were in a domain. So to summarize, the strengths of my work is that we have individual patient data, uniform reporting of clinical manifestation, and detailed information about the clinical manifestation. But our limitations are that we have a rare disorder with a low patient number and a different description of the phenotype and the genotype, and also missing information about the genetic background, and a lot of research is needed. And going on with my second project, which is investigating the association between the vitamin D levels and the malignant transformation of intestinal polyps in pediatric patients with polyposis syndrome, where we would like to develop a systematic review and meta-analysis, and firstly a prospective multi-centered study. Shortly about the background here. Colorectal cancer is the third most common cancer in both sexes, and 90% of it occurs from gastrointestinal polyps. Therefore, the question arises if prevention for these patients is possible, and if we could start prevention already in childhood. According to previous studies, vitamin D as a chemopreventive factor could be possible in several tumors due to its antiproliferative, pro-apoptotic, and immunomodulatory effects. So we can see that vitamin D as a chemopreventive method could be possible, and we want to check if that's possible also in colorectal polyps to see if the transformation could be lowered. So my clinical question is, does the vitamin D level influence the disease course in patients with polyposis syndrome? Our population is pediatric patients with polyposis syndrome. The exposure are low vitamin D level compared with the normal vitamin D level in the polyps, and the first outcome is the malignant transformation, and the second outcome is the onset, disease course, and chemoprevention. Our hypothesis is that the low vitamin D level affects the course of the disease negatively in patients with polyposis syndromes. Currently, with my second project, we are gathering the patients in Budapest to start the work. And to summarize, the aim of my study is to gain a comprehensive understanding of polyposis syndrome, to discern the course of the disease, and to probably find a way to lower the malignant transformation in these patients. I would like to finish with one of my favorite quotes, which is, learning and enjoyment are the secret to a fulfilled life. Learning without enjoyment wears you down, and enjoyment without learning dulls you. Thank you very much for your kind attention.
My question would be whether you include also data on the second project with COX-2 inhibitors or AS5 or aspirin and other chemopreventive drugs that are used in this field?
Actually, no, not in the second project. There we would like to focus on the vitamin D levels, but in the first project we are checking if the patients got any of these medicines and if they're working and what the effect of them was.
Because I know that the number of the patient is low, but it would be worse to distinguish those patients who are taking COX-2 inhibitors or any drugs working on this receptor, and whether or not, because this could bias your data.
Yes, thank you very much for your help.
Congratulations for your presentation.
Thank you.
I would like to just ask about the first project. What is the difference between the likely pathogenic and the pathogenic categories?
Well, currently, so these American College for Medical Genomics and Genetics, they have a big table on factors, how to put the mutations. So if all the factors are positive, basically you get a pathogenic, and depending on the lower point of missing information, it gets likely pathogenic, but it's very different. Like, it depends on the mutations and which points are positive and which are not. So
thank you.
A lot of factors. Thank you very much.
Any more questions from the audience? Yes, Jimin?
So in your first project, you mentioned that different genotypes can cause different malignant transformation. Do you think that different genotypes can affect the vitamin D metabolism in your second project?
I'm sorry?
Do you think that different genotypes can affect the vitamin D metabolism regarding your second project?
That's a very good question. Thank you very much. Well, it could be possible, but to be honest, I don't know, but I will look into it. Thank you for your comment.